हेलो। Hi, Mohammed. Hi, Moha. Hello. 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 Poa. Niko poa. Kwa prof. Oh, ni sawa tu. UCT. Oh, Okay, mi niko class. It's going to start like at 12:30. I usually have a class today on Fridays. Kwa klasi ya usi ndipo klasi inakuanga. Sawa. Sema. Hmm? I don't know. I don't know. Prof. Basura. There's a prof from the States, from Pennsylvania, as part of my program. So he teaches me lateral scalpels. So we do lectures and then comes twice a year. Twice a year he comes na really Kokola. Kuperea hiyo maneno kama yenye tunafanyanga Kenya hakuna. Ati somebody from outside comes and operates. I've never seen that.
Yeah, so now this is going to be for the 1 year to it over.
Yeah.
For you to get access to it.
Exactly.
That idea.
So, I'm just waiting for that class. It starts at 12:30. Sometimes the registrar in October. So today is the first class of the year. Nobody is Maybe it's going to be vestibular.
Well, but you had other. It can help.
It's every Friday, every Friday. Because already me, I've already done my 2 labs with him. Next time he's coming is in May.
Yeah.
Anakuja kwa mimi. I think April, May, yeah, April, May he'll come. Then they sit in the lab for a week. Inakwanga an intense week. Monday to Friday, 8 to 5 p.m.
8 to 5 p.m.
Drilling, yeah. Only. Yeah, fine. Woo. Then alifanya mtoto vasectomy peke yangu.
Yeah, you will get.
I'm so happy. By the way, and I understand. Hata nina understand ya kina nani. You know kwenye iko. Hapo kwa cochlea hapo katikati hapo. It is such a dangerous place.
That is like the most difficult place.
No, the most difficult to access is the internal auditory.
I see.
But here, tunafanyanga, I can do it. I've never done on a patient, but I've done on a cadaver. I'm even gonna do one tomorrow. Get my lab tomorrow morning. Silab uko na key zako. You do anytime you want. Or rather for my lab, I do anytime you want. So I'll go tomorrow. When I'm on call over the weekend, nafanya route, nitaka uko site. You do. Yeah. Okay, good jana. Yes.
I want to consider the profile this morning.
Sorry?
I want to invest that. I want to read that.
No, you are not rude. You were just, it was a genuine concern. Yeah, I don't think you were rude.
Sometimes I say something in my head, else too.
Maybe people just misunderstand, but you are not rude. You sounded, because level headed, but fine.
There's more, but you can't say more.
Good jana. Jana. Normal food for once.
Hata nilisahau kama niko
Uko nyumbani. Nilikaa nilienda home hata nililala Then I had a woke up with a headache. Woke up with a headache. But napatanga migraines kwa sababu ya macho.
I need to buy it.
hata nilipenda mine is tension.
Tension. Uko na tension?
No.
Oh,
I just have tension. Nikisimama kwa not that I have tension. Because like what?
Yeah, good.
I might concentrate so much.
In talking and lenses, so my eyes are not able to adjust against light. And so I'm always wearing sunglasses. Half the time I forget them. Like now I don't know. I lost them I think yesterday.
The dark ones. You need to wear that one.
I need to wear the dark ones, especially in the sun. And then occasionally once in a while, I find myself having a headache.
Hey, can you hear me?
Yes, we
Yes,
can
we
hear
can
you.
hear you. Hi.
Hey guys,
How's it?
Hi.
how are you?
Hi,
Fine,
Prof.
thank
How are you?
How you?
Good,
Nice to
good.
see you.
Same
Happy
here.
New Year. Nice to see you too.
It's been a while. Happy New Year.
Happy New Year to you too.
Yeah. So one of my old colleagues from Michigan, Batul, she's going to be coming on, I think, and she's going to talk about vestibular today. Okay.
Good.
So hopefully, yeah, she should be getting on hopefully soon. Oh, there she is. Hey, Batul.
Good morning. I made it.
Hey, rise and
Hi.
shine.
It's earlier for you. I know.
Yeah, yeah. How are you?
I'm doing well. I came to clinic because my internet's kind of spotty at home. I didn't want it to turn off on you guys.
Yeah, great. Excellent. Well,
Yeah.
good. Let's see. Can you want to try to share your screen?
Yeah.
I think she should be able to share her screen now.
Great. And Batul, this is Lillian. Lillian's our Cape Town fellow from Kenya. And that's Gift. He's one of the residents. He's from Zimbabwe.
Hello.
And this is Batul. She's an audiologist, vestibular extraordinaire.
I don't know. Depending on the time of day.
5:30 in the morning. Definitely extraordinaire. 30.
Can you
Yeah.
guys see that okay?
Yeah, I think you're kind of in presenter mode. Can you
Oh,
or you're yeah, it's kind of can you
I
hit
don't have
the
notes. Is it
yeah,
better?
there you go. That's the one. You
Okay.
got it. Perfect. Well,
Cool.
Lillian Gift, was anybody else getting on the call today or should we get started?
Let me find out if
Let's find out.
Shabina is you would want to join. Give me 1 minute.
Sure.
I'm timing you. 1 minute starts now.
Right. She'll sign off. I mean, don't trust me. She'll be in the vapor. We'll never hear from her again.
How's New Zealand?
It's good. Yeah,
Good.
it's yeah. Yeah, it's definitely warmer.
I know. We had a really bad snowstorm yesterday.
Yeah, it's been cold in Western PA. It's weird yeah, strange. So yeah.
All right, I think we can start.
Okay.
Okay.
Batul, it's okay if we record this. Typically we record these lectures and then they store those on a central computer there, which is nice for folks that want to go back to it or folks that missed the call.
Cool. Yeah, no, absolutely.
All
So
right. Take it
I'm
away.
ready. So the topic for today is just to go over the different types of vestibular tests. There are a lot of them, so I focus more heavily on the formal and the informal ways you can do the testing. So I don't have time to go through all the anatomy, but if you have questions, please interrupt me and just ask away, because that would be an entire hour on its own. But I do have a lot of really cool videos. So I'm going to go review all the different vestibular tests. I do have case examples, and then ask me questions at any point, but I do have time at the end for questions. But a little bit of why vestibular testing is important and why people come in to see us. It is the third most common symptom in primary care setting. I found this fact interesting. 20 to 30% of people will experience dizziness at some point in their lives, and as they get older, they're at increased risk. It does not mean it's always related to an inner ear pathology, but sure enough, they do report dizziness at some point. If it's untreated or if it becomes chronic, it does certainly impact their quality of life. A lot of people just become recluse, try not to go out just out of fear of having another vestibular attack. So it's very important for us to give them a formal diagnosis and get them the care they need. But what is our role? We just want to rule out or rule in if it's an otologic condition. So I tried to outline all the different types, causes of dizziness, but what our testing will focus on is whether it's otologic in nature. But certainly based on the case history, sometimes we can suspect neurological and send them to neuro. There are also instances where it seems more cardiovascular, and a lot of times in those cases, our tests are normal, and it just comes down to the entire clinical picture. I always tell patients, dizziness is like a three-legged stool. One of the legs is the ear, the other is the vision, and the other is their muscles and joints. If one leg is a little wobbly, the whole stool's wobbly. But I can at least tell them if that leg for the inner ear is healthy or not. But what does it mean to be dizzy? Just in my 4 years of doing this, I have heard so many different types, descriptions. So I do think it's important when someone says they're dizzy to ask them, can you characterize it for me? How would you describe it? Without necessarily feeding them words. Like, is it spinning? Are you spinning? Just kind of see how they characterize it. I always like to write in my report how they described it. I've heard swimming, floating, lightheadedness, foggy, self-spinning or room spinning. My favorite is a patient once said they feel like their head's a snow globe and someone shook it. And they just feels like they get this weird head fog from all the time. So that was an interesting description, but it certainly ruled out a lot of other types of causes of dizziness just based off that. And for some, it means unsteady. They don't say they're imbalanced, they tell us they're dizzy. So I do think the case history is probably one of the most important things we can do. And we take a lot of, at least I do, I take a lot of time talking to them and figuring out what brings them in today. But as they're talking to me, the two things I'm trying to answer, the timing of their episodes and what are their common triggers. So in terms of timing, is it episodic? Does it just happen in random events? And are they symptom-free in between those events? Or is it something that's more constant? Like they always feel they're dizzy and they're really never in a healthy state subjectively. And for some, it could fluctuate, and it's for others, they feel like it's getting progressively worse over time. And in terms of duration, it can vary from seconds, minutes, hours, or days. So it's always important to kind of ask them how long these episodes last. Even if they tell you it lasts all day, I'm like, I'm sure you're experiencing dizziness all day, but per episode, how long do those episodes last? And sure enough, sometimes they just say, oh no, they're seconds, but every time I turn, it kicks in again. And then what are their triggers? For some, it's positional. It can be related to movements. Others, it could be environmental, like light sensitivity, noise. For some, it's food. And if they don't know, I would recommend having them like create a diary log of their symptoms. I will find this population's really good at following instructions, and they often come back with a notebook of different logs. So careful what you wish for. And other things we'd like to ask is on top of their vestibular episodes, what other symptoms are they experiencing? Are they experiencing hearing loss in one or both ears? Are there any headaches, ear fullness, any other otologic concerns we need to be worried about? And in terms of symptom quality, I ranked this the lowest because it's very variable, it's unreliable. Someone can tell me their episodes are 9 out of 10 in severity, but to someone else that could be 2 out of 10. I do think it's important to ask that, but the main thing I would focus on are the timing of their episodes and their triggers. Why are we asking all that? Because I'm about to assess their VOR. So I just put a little slide on that just to it will help when we go through the testing. So the vestibular ocular reflex is what we measure, more specifically the horizontal one. So that's what helps us maintain fixation on a target. So if I turn my head when I'm staring at something, my eyes move in the opposite direction. We can thank our VOR for that. So it does incorporate both the visual and the vestibular system, tying them all together. So it does look at the semicircular canal, the horizontal, and the eye fixation. It does not need a visual stimulus, so I can close my eyes and turn my head. My eyes are still moving. Even in patients who are born blind, we can still assess their VOR, and I've done that in certain patients. Certain tests you can't do, but sure enough, we're able to test that. And then how does it work? It is the 3 neuron arc. The first order is the primary afferent fibers, vestibular nuclei, and then the motor neurons. I just think of it as it starts with a sensory portion with the semicircular canal. It goes more to the brainstem, which sends it to the pathway to get our eyes to move. So this is how my brain works. I like to know what each test that we offer looks at and what part of the vestibular organ is it tapping into. These are the main tests that we look at. So calorics, rotary chair, and VHIT, they all tap into the horizontal canal and the superior vestibular nerve. The only test that assesses the inferior is the CVEMP. So both VEMPs look at the otoliths. The OVEMP captures the utricle and the CVEMP captures the saccule, but it does go through the inferior nerve. And then the cochlear organ is like when we do the hearing test, the ABR, the acoustic reflex. Although they share a space anatomically, none of our vestibular tests tap into that. They will need a hearing test for that. This doesn't include the bedside exams I will get into, but when I try to think of what tests to do next, this is what I picture. I also think of almost like an audiogram. It could be the audiologist in me. I like to picture all the tests like I'm plotting out a hearing test because every test taps into a different frequency. It does not mean we need to do every single test. There's clinical judgment for that. But so for example, calorics is a low frequency versus a head thrust is a more of a high frequency. I did add VEMPs on the far right because it's all the way at 500 hertz. It's very high frequency. But the others for spontaneous and gaze, I put 0 hertz just because we do those tests without them moving their head. So when you think of frequency, think of rotation and having them move. And then VHIT's there, head shake, but just keep that in mind as we go through it. It's how I like to think of all the different tests we do. So how do we test them? Most commonly is the VNG. It used to be done with an ENG with electrodes, but I will say I can't think of anyone that does that anymore. So with the VNG, there is a camera that does measure the eye movements with the goggles, and then it relies on the pupil localization. So we're trying to calculate the position of the pupil and the angle of the gaze. The software does that on the back end. And then a lot of times it gives you like the nystagmus printed out, but I always like have I cover that for the students and watch the video because sometimes they can give you false responses. You want to be able to use clinical correlation with the video, but it has to be with the eyes open because that's what it's picking up, the pupil. This is how we start the VNG battery. We start with the oculomotor tests. These are the 3 main ones: gaze, saccades, tracking, and pursuits. All these 3 look more as rule out a central pathology. So this is the gaze testing. This can be done with or without the goggles. You can certainly do this as a bedside exam as well, even if you don't have the goggles. So how it works is you want them to look rightward, hold their gaze, and you want to be able to assess if you can see nystagmus in room light. And then you can go to the left, up, down, and central gaze. That will look at your spontaneous. If you do see nystagmus, I would recommend waiting at least a minute because sometimes you can see it alternating and changing direction, and you may have missed that if you didn't wait. Also avoid the end range. The reason it's at 30 degrees, because if you go too far, you are going to see some form of nystagmus. So you don't have to be exactly at 30 degrees, but on ballpark, just don't go too far into the peripheral. And it assesses all the eye muscles. So the 3 questions we want to answer when you're in the exam room is what direction of the nystagmus you're seeing. Is it right beat, left beat? What's the intensity? Is it changing direction? That's very key to know if it's a central pathology. And in what positions are you seeing it? Are you only seeing it in rightward gaze, up, down, left, or central? So these are the 3 things you really should highlight when you're doing that test. The reason for that is you want to parse out, is it more peripheral in origin or is it more central? For peripheral, it's going to be direction fixed, meaning you're either going to see all right beat or all left beat. It is always going to be horizontal with a slight torsion. And then if you give them something to fixate on, like a target, this is more so if you have the goggles, because you do it in vision denied, it should quickly suppress. For central, it can change in one gaze position or the other. It can be right beat in one, then switch to left beat when you go to the other side. I do have a video on that. In some cases, it could be vertical, where you see more of a downbeat. Horizontal is rarely observed in the primary position, but you will see that bidirectional where it changes from right to left. And sometimes if you give them that light, it will enhance. So I've seen the nystagmus just get stronger when you give them a target. This is a peripheral example where you're going to see a left beat when they were looking to the left. Nystagmus is really, really cool, especially on video. I always try to look in one spot in that eye to see which way it's going. And then that's with the fixation, and see how it quickly suppressed. So that is a clear indicator that it's peripheral in origin. This is central. You're going to see a downbeat. It's almost like her eyes getting pulled downwards. And this one is bidirectional, so you're going to see it. It's very subtle on the right beat, but then you'll see it a little stronger when she turns to the left, and then you'll see a left beat. So this is direction changing, also a central indicator. The second part of the oculomotor test is saccades. This is also something you can do on bedside without the fancy equipment. But what are saccades? We generate fast eye movements that redirect the gaze from one target to the other. So the eyes must move as quickly as possible to minimize the amount of time the eye is spent on that and to reduce blindness. It is the fastest type of movement in our body. So it places the highest demand on our ocular muscles. So the saccadic velocity is the first sign of many muscular or neurological abnormalities. However, in elderly patients, we need to take that into consideration and make sure what is their visual status. Are you taking off their glasses when you're doing this exam and then you're getting what looks to be abnormal, but it could just be they cannot see the target. So it's important to keep that in mind. The way you would do it bedside, but I want to show you how it's done in clinic. So they will see a green dot and it just starts to jump around in a more horizontal fashion. And we're going to look at accuracy of their target and how quickly they are reaching that. If you're doing it as a bedside exam, you would almost hold like your pen up on one side, then quickly have them turn to the other, back and forth at random. That also will assess the same thing, although you won't be able to get the accuracy, velocity, or latency, but you'll be able to see, is it a smooth transition or is it more jaggedy in terms of their eye movements? The accuracy is how close the eye comes to acquiring that target. Velocity is the speed of the eye at acquiring it. Latency is the most important one. It's the time it takes them to acquire it. If this part's abnormal, that's when I'm more concerned. accuracy is a hit or miss, especially depending on age. The younger they are, the more they're just looking everywhere. And then this is what we look at. When the software does plot it out for us, anything in the gray region is abnormal. However, sometimes you can go in and clean up the tracing if they like lost interest a little bit and then regained it. So it's important to look at the entire clinical picture. Pursuit is my favorite test. It's when you see, there's a video of that as well, the dot go back and forth and it just slowly starts to pick up speed. It's a voluntary ocular motor control system. That's because they willingly have to follow the target versus saccades happen naturally by just turning our heads. So this one's driven entirely by moving the visual stimulus. It goes by 30 degrees right to and then to the left, back and forth. 0.2 to 0.8 hertz, that's just the speed that it goes at. And then if it exceeds 60 degrees, there's just no way to keep following that target accurately. So it has to go a little bit more smoothly and slower. And then this one's also age can play a factor. There are age corrected norms. So keep that in mind if you're doing it as bedside. So for that one, you would just, there's a video, I found one, but I want to show you how it's done in clinic. So that green dot will just go smoothly back and forth. This one just captures how it goes smoothly, but you can just see how her eye is slowly following it back and forth. And then it starts to pick up speed relatively quickly. So we are looking at gain, how the eye movement's following the target. The symmetry, is it just as smoothly going leftward and then rightward? And then the angle, the one on the bottom is abnormal. So I want to show you what it would look like. The eye is just having a very hard time following it. It looks almost saccadic in nature. Just, it's not as smooth as hers. So although on bedside, you won't be able to measure gain, symmetry, or angle, but you'll be able to see the difference from what a normal eye exam would look like and then an abnormal. This is how you can do it. And then you can just do it at different speeds. Dix-Hall Pike. I'm sure a lot of you know what that is. This is the test that will assess whether there is BBPV present. And then it's named after the researcher who developed it. So kudos to him. You are able to measure the nystagmus while the head is held in various planes. So to see if it's positive on the left, you will turn the head left or right, 45 degrees, have them come back, right? You are supporting their neck. You can do it with their head off the table, but for patients that are older or have neck issues, you can put a pillow on their back, so when they lay down, they're still at an angle, but you still can give them that support. And then you want to see, you can just look without the goggles to see if you see nystagmus and whether it's upbeating. And then you would sit them back up. If it is positive, I would still recommend before you jump into treatment and do the appli to check if the other side is positive, because sometimes they can have multi-canal BBPV and one side could be stronger than the other and you want to treat the stronger side. There's another one you can do where you can check for anterior is when you bring their head all the way back. And that's the one time where if you do see downbeat, that's probably just an anterior BBPV, but you will see a reversal when they sit back up and then it changes to a beat. Here's a positive left. And you want to see how quickly it can fatigue because it kind of lets you know what type. Caloric testing. This is the one you cannot do as bedside exam if you don't have the equipment, but this is the gold standard for assessing whether it's a unilateral vestibular loss. It is, like I said earlier, a very low frequency. It's 0.003 hertz, and it only assesses the lateral canals. And then it looks at the integrity of the right and the left horizontal, because it does also pass through the superior vestibular nerve at the same time, but it does allow us to assess each labyrinth separately. It also allows us, it's always abnormal if there's an organ impairment, once you've ruled out tasking and made sure they weren't suppressing, but if it's abnormal, it's a sure thing. And then caloric test, it's the only, assesses the very small portion of the vestibular system. So it doesn't really tap into the higher frequencies. One interesting fact, it hasn't been, this test hasn't been revised since 1942. But what are the things we look at when we do the caloric test? We want to see, is there a unilateral weakness? Is one side weaker than the other? Are they both out? Then it'd be a bilateral weakness. Can they fixate? We can also check for fixation there. It's important to turn on the light before they naturally start to suppress that response. And then directional preponderance, that just doesn't look at ears. It looks at either right beat or left beat. So how does it work? It elicits a response from, like I said, the horizontal canal through a convection current. So think warm fluid gas rises, it's less dense, cold falls because it's more dense. So warm air or water can irrigate the endolymph to become less dense, and you see a deflection of the cupula towards the utricle, which is why you see it beat towards the side that you are stimulating, versus with cold water or air, it will beat away from it because it's deflecting the cupula away from the utricle with a decreased firing rate. It can be done through air or water. There are two different schools of thought. Some people think water is superior than air. I think it comes down to the clinician, because air needs more technical skills to make sure you're on the TM for an entire 60 seconds, versus with water, all you have to do is let the water flow, and it's hard to miss the TM that way. So I do think they're both great. It does come down to who's doing them. And then the patient has to be supine and they have to be 30 degrees. It just puts the horizontal canal at the most optimal stimulation level. And there are specific temperatures to do it there. So 44 Celsius for warm and then 30 for cool. If you are doing water, you're only irrigating for 30 seconds. For air, it's 60 seconds because it just takes longer to stimulate. For unilateral weakness, every site has different norms. Our site, if it's 25% or greater difference, that's considered abnormal. But I've seen it where some people need it to be greater than 30. Research is pretty split. It's anywhere between 20 to 30 difference to call it abnormal. But there is a formula. It calculates the right total and then subtracted from the left, divided by the total of all the caloric responses, and then you get a percent of that. For a bilateral, both ears are essentially out. This is also one where the norms vary, but ultimately most people try to want anything below 22 degrees total is a bilateral weakness. This one, not many people know about. It's pretty rare. If you have hyperactive responses, it could be an indicator of a central a lesion, more cerebellar, but you have to have total like caloric responses of 221. Like this patient had 75, 72, and then 62. Like this is super hyperactive, super abnormal, but it's important to make sure there isn't something else going on, or it's sometimes if they're super anxious, that can also impact their responses too. So again, clinical judgment is indicated. Or if mastoidectomy, anytime there's a surgical ear, it's really hard to confidently say there's symmetry. You can confirm function on both sides, but that's when you would need to rely on the other tests like VHIT to truly assess the end organ, because the transmission of fluid or air is different on an ear that's been surgically altered, especially if there's like a perforation or an ear tube. So these are the precautions. I'm going to keep saying it does not assess the entire peripheral vestibular system, but everyone loves calorics. And then we do infer the status of it through that. Ensure that eardrum is intact, and there has been no surgical modification of the ear that would affect heat transmission. If there was, they're certainly still eligible for testing. You just have to assess and interpret everything with caution. Just see what the entire clinical picture shows. And then water in the reservoir must be replaced frequently. And then the irrigation tip should be replaced after each use. So we tend to replace it per patient. Same thing for air. It's just a tip that gets changed. And then rotary chair is also a great test. This one is the gold standard for a bilateral weakness versus calorics is the gold standard for a unilateral weakness. So this one assesses both horizontal canals at the same time in the vestibular nerves. So you can't really isolate left or right here. But it is the same pathway as calorics. So the way it works is the rotations towards the right results in excitation of the right labyrinth, and then it inhibits the left and vice versa as it goes the other way. It also assesses the central vestibular system because it does tap into the vestibular nuclei in the cerebellum. And then I just always like to give this visual because it helps me realize what frequencies the rotary chair is capturing in the normal head motion. So it has to be done in a very controlled environment if we want to gather like the gain, the symmetry, and the phase. But this is another one where you can also do bedside just to see. I've done it for pediatric patients who just were too fearful of going into the chair. But it's just like this rotation. I always joke with patients, I'm like, it's an awkward dance move. It just sways left and right, and you're going to be in the dark all alone. But it really is like that. It just sways. And then it doesn't give, the reason they're in the dark too, on top of not suppressing the VOR, is we don't want to give the body any spatial cues. Doesn't know which way is going. Is the eye moving in the opposite direction of the body? Same thing, it has to be tilted 30 degrees to stimulate the horizontal canal in the most optimal direction. And we can move it at different frequencies from 0.01 all the way. I've seen it go up to 1.34, but clinically, we don't really go up more than 0.64 for that. The reason is the gold standard for bilaterals, because sometimes patients could suppress a caloric, but if you get normal gain on chair, then something went wrong with the caloric test. They shouldn't have normal gain, especially at the lows. They can certainly still have normal gain in the mid to highs, but not in 0.01. I just thought this was a fun video to see how it sways back and forth. There are different types of rotary chairs. Some are more in a chamber. Industry is going more towards open chair with goggle covered. You will not, it's very, they're essentially going to stop making the ones that are more in the chamber. But again, we look at gain, symmetry, and phase. If gain is normal, then you can interpret symmetry and phase. If gain is reduced, it's not enough to truly get accurate symmetry and phase to see. If you do have like a unilateral weakness with normal gain, sometimes you might see phase leads, and that just tells you whether their weakness is compensated or uncompensated. This is how you can do it in clinic. All it does is it shows you, if you spin them to the right and look, can you trigger a nystagmus? And if you spin them the other way, can you stop the chair and just stare in their eyes and see if you can see a nystagmus? Then you would have ruled out a bilateral weakness. This one doesn't stop because the video got a little awkward, so I had to trim it. But you can spin them. I've done it in little kids where I just wanted to confirm if they have a bilateral weakness, where I would spin them really fast and then stop and like stare at their eyes. You should be able to see nystagmus right away. And that will, then you can confidently know that there's at least no bilateral weakness. Again, it doesn't let us know if there is a unilateral. but there are other tests like VHIT that will tell us. This is the only test that will assess all semicircular canals individually. It does the posterior, anterior, and the laterals. The lateral one is the one that would correlate with calorics. I will say you have to have a 40% weakness or greater for VHIT to truly show reduced gain on that side, but mainly because it's more of a high frequency test and caloric still a low frequency, but it does allow us to tap into each canal. So you can sit them in the chair. This is also a test you can do bedside, and I'll show you on the next slide. And then you want to give them a target at least 1 meter away if you're using the goggles. Now, if you're doing it as bedside and they're staring at you and you're moving their head, they can stare at your nose. But you want to move their head abruptly, but not all the way around. Like I would say like at least 10 degrees. And then it should be able to pick up their eye movements that way. It shouldn't take more than 5 to 10 minutes. A lot of people just do the laterals because the other ones are a little tricky to get, but if you can, it would be really helpful just to assess those canals. This is a video. There are 2 different goggles on him, and that's just 2 different manufacturers. They all do the same thing, and those are the Ralph and the Lark planes. Does measure the head velocity in comparison to the eye velocity. A normal gain is usually around 0.78 or greater in adults and 0.6 in pediatrics. But what we're looking for are saccades. Are there any overt or covert saccades? Overt happens after the head movement, so this is something you can see in office. Coverts you can't really see with the naked eye, and that's where you would need to see with the goggles. But if you see overt saccades, then you know based on their peripheral weakness, they're not compensated, something's still happening and they're still symptomatic. But if you see on the next one, it's a different software. I like this old one more, but you can see, so the covert saccades happen during head movements. I don't know if you can see my mouse, but like it's all these here, and these are overt saccades. So this happened after their head stopped moving, their eye still lagged. And then the right had reduced gain and the left was normal. You can do it as bedside as just a head impulse. So you just drop the word video, but it should be in the direction of the impaired system. Oh, I think that's not it. She was staring at her nose. This is a post head shake video that's coming up. No spoilers yet. On top of those bedside vestibular exams, I do want to go over some more because these will still allow you to assess the VOR and either support or refute a hypothesis about the diagnosis you suspect, because based on your conversation with your patient, you are going to suspect something. So they can certainly tell you a suspicion and whether further testing is indicated. So for post head shake, if a person has an impaired VOR, their eye will slip off the target when the head is rotating towards the affected ear, but it will be towards their intact side with post head shake. So if you see a left beat, you might want to suspect a right weakness. It gets tricky. It depends how soon you see them after an attack, but if it takes them a couple of weeks to see you, then that's accurate. But a lot of times people don't do it, but you have to angle their head for 30 degrees forward to get the most optimal response. But I've seen it done the other way and it's still okay. But again, you want to move their head back and forth. And then see 3 degrees or greater within 5 seconds. You can see with the naked eye. Anything less than that, the camera can pick up. And then if it's peripheral, if it's you see a horizontal nystagmus, I have seen it sometimes where you just start to see that downbeat, similar to the video earlier. And this is the video that was playing over there. So you're going to see a positive post head shake.
But 12 quick questions. So when you do the head shake, how how do you determine sort of your frequency of the shake? Do you count to yourself, or what's your periodicity on your shake? Do you know what I mean?
Yeah, I try to do within 15 to 20 total. So at least 10 shakes.
15 or total, yeah, but at what kind of which speed do you like to go at? I mean, like how quickly are you shaking the
Relatively
head?
quickly.
Yeah, but you do like 15 or 20 like completions, like cycles. Is that what you said?
Yeah, so like it
Mm.
would go like left 10 and like, yeah, back and forth. So I just kept counting to 20 total. So I always tell them
Mhm.
it's like you're saying no, and I'm like just moving their head. But the way I'm holding it is like I'm not letting them go too far. But yeah, I try to go as fast as comfortable for them just to see, because I want to stimulate that VOR as much as
Mhm.
possible.
Yeah.
Is that what you do?
Yeah, pretty similar. Yeah. And I say when I stop, when I say open your eyes, I want you to just look straight ahead. This is kind of what I tell them. Just do the best you can. Yeah. Mhm.
I will say with the goggles, I just have them keep their eyes open.
Yeah.
But I know without
Yeah.
them, they're gonna want to close their eyes because there's too much
Oh
in
yeah,
the
too much. Yes, yes.
to look at. But with the goggles, because it's hard sometimes, because by the time they open their eyes, I feel like I lose it. But that's only for the recording purposes.
Right.
Close your eyes.
This is on a pediatric one.
Open your eyes.
Again, different speed. I don't think I would have gone that fast with this kiddo, but it's a good way to see how like it can be done. This was done by a PT.
Close your eyes.
Oh, it goes again. Here's another one of the eye. That was also positive. And you'll see it like within that first 5 seconds. Any questions about anything so far? We're almost done. Okay. And then Romberg, this is used to also assess their ability to control their balance while standing. It's most widely used screening tool. And how you perform it is they close their eyes, their arms are crossed on their chest, and they're standing for 20 to 30 seconds. If it's abnormal, if they fall, move their feet, sometimes you see them start to sway. Or here's a video.
Okay, there we
He starts to sway. If you're alone in clinic, sometimes I'm the only one and I don't have someone. Sometimes I have them do it closer to a corner in the room. And then if they do sway towards me, I'm able to catch them. And if they sway towards the wall, they'll hit the wall. That's going to be abnormal anyway. But it's my way of ensuring their safety. I'm not as strong as I look. So I do want to make sure they all leave intact and healthy, and I don't have to catch anyone. So that's one way I do it, is I have them do it in the corner if I can. And then for the Fukuda, you should be able to do it if they're able to do the Romberg testing with their eyes closed, because here they'll close their eyes, they'll extend their arms in front of their body, and they'll march in place for 50 steps. And if you see them deviate for 45 degrees or they can't complete it, that's an abnormal exam. And then you want to look at the angle, the direction, and the distance of the deviation. So this is one. Let's get going. Again, use that corner to your advantage if you have to. This is a tandem walk. This just helps you look if it's affecting their daily activities. You want them to walk heel to toe, and just to see if you see any excessive sway, staggering. You do this with eyes open. But it's just helpful to know how much it's impacting them, especially if you suspect like a bilateral weakness in the individual. So then you would want to do PT sooner, proactively, if testing is going to take a while to get into. I like to put these summaries, really for me, but also it's a lot. So for a unilateral weakness, you might see a head impulse towards the affected side and a head shake towards, away from the affected side. It just like it's not always accurate, but this is a good, more often than not, something to go by, and it just helps you suspect which side, it's gonna happen. And then for bilats, sometimes you see nystagmus, sometimes you don't. Their head impulse is bilateral, so when you do it, it's not gonna be normal. For head shake, it's likely negative. You're not really gonna see an asymmetry. A lot of these individuals, it's really hard to get nystagmus on them. Central, downbeat, direction changing, and then head impulse is normal because it's not a peripheral dysfunction. Head shake may be downbeating after horizontal head shake, maybe not. Any questions? How fast? Oh, I didn't go too bad. I was good on time. I had a whole thing on VEMS, and I'm like, I'm not gonna go through VEMS and the electrodes today. I wanted to focus more on like the tests that you should see more day to day, that really will give us a better clinical picture on these patients.
Thank you very
Yeah,
much.
totally.
I just have a question on maybe on Rombeck test. Well, one of our vestibular specialists here use a modified Rombeck where you try and see, you escalate your Rombeck test to a ped where the patient has to balance, and it kind of gives you, or it confirms the positivity or negativity of the Rombeck test. I don't know if you have any utility regarding that.
Yeah, I've heard of it. It's a great one to do. One test I didn't put in there was like posturography. Another, because we know we're going to do more of those tests, so we defer on that one clinically. But I agree. I think that's a great test to do, because it does tap into two different vestibular tests and still assesses how they're functioning.
We call that a sharpened Romberg test, and I'm not sure if it's exactly what you're referring to, but we'll have them just stand with one foot in front of the other and close their eyes, and that accentuates the imbalance if they have a mild imbalance with Romberg. The other thing that I'll do sometimes on a Romberg test that I think is sometimes useful, if a patient is in a Romberg position with their eyes closed and they're swaying a lot or kind of exaggerated body motions, but they maintain their balance even though they're doing unusual motions, or they know to kind of, they'll step to catch themselves. I'll sometimes just ask a patient to hold their arms out straight in front of them with their eyes closed, and I'll move their arm and tell them to put their arm right back where it was with some distraction. And so the idea is that some people exaggerate their Romberg test, and by having them hold their arms out and by moving their arms, putting them back into position, if they don't sway a lot and do crazy things when you're moving their arms around, but they do when you're just having them hold still, it may indicate there's a functional component to the Romberg test that is they're not being fully cooperative. They're not doing their very best Romberg. If you can distract them and they then can do more difficult motions or more difficult balance acts with their arms moving around. Does that make any sense? You ever do anything like that, Greg?
I haven't actually. That's interesting. Yeah. No, it's an interesting point. Sometimes, I wish we had things like posturography type materials like foam, things like you may put them on, some people do that in like neurology clinics. So you stand on foam, like an uneven surface. I noticed in the video, the Romberg, they had the patient's feet like really narrowed right together. I kind of have them more like shoulder width apart. I mean, I think it's hard. It makes you wonder. It's hard structurally sometimes for people like with lower extremity weakness. They may have like orthopedic issues when your feet are like pasted to each other. I think it's really hard for some people that might be bull-legged or they're knock-kneed. There may be, or just, that's really a tough thing. So it may be kind of an inaccurate. I don't know, Batul, what do you think on that? Do you have their feet right together, or do you have them spaced?
I try to have them separate as far as it's
Yeah.
comfortable. But I
Yeah.
have seen
Yeah.
RPTs not be as spaced out, having them do it. So I guess it
Yeah.
just depends. I've seen it done both ways.
Mhm. Yeah.
I
But it's
always
interesting,
put 'em
Brad.
right together.
Do you put them right together? Okay. Yeah, it's
Yeah,
interesting.
yeah.
Yeah. But those are little nuances. I think it'd be fascinating to do some polling of, little subtle nuances like we talked about from clinic to clinic, like how people actually are doing some of these tests, because um I don't know. I mean, it just makes you wonder about the interpretability. If you're doing them a certain way, what does it mean? I mean, I don't know.
I think it's just, it increases the difficulty, as you say,
Yeah,
if their feet are
certainly
directly
does.
together. If they
Yeah.
can do it with their feet directly together, then they
Yeah.
should be able to do it with their
Right.
feet slightly spaced apart.
Yeah.
So,
Yeah. But I've seen
Yeah.
kind of what you're describing with just the Romberg, where they stand there and then their eyes close and then they're just flailing. They're just, I mean, it's like this, like, and then the
Yeah,
eyes
and then if
open and then they're totally fine. It's almost, I don't know. It's just like, it's really a fascinating, like, over exaggeration of visual input removal. You know what I mean? It's like, wow,
try that distraction test with the arms and see if they can do that,
yeah,
then if
yeah,
they're being fully
that's kind of
cooperative or not.
interesting. Yeah, that's an interesting concept. Yeah.
That was a great talk. You
That
did really
three-legged
nice.
Yeah.
stool.
What's that?
It's
What'd
that
you say,
three-legged
Batul?
stool I was telling you about in the
It is.
beginning.
That's right.
It really,
That's
and
right.
then they start to wobble.
Yeah. So I do have a quick question about BPPV.
Yeah.
So I know to check, in your how you do it clinically, you're checking for mostly posterior canal. Do you ever check for horizontal canal? Or are you looking for that? How do you do that and integrate that? Do you ever go head center supine, or do you put them in a D cube position straight?
We do like the roll test in
Yeah.
clinic.
Yeah.
And a lot of times our appointments are coordinated with PT and they prefer to do those. And then we just focus more like from the audiology side on the posterior. And then I like to check the anterior if they tell me it happens when they're in the shower, only when they're looking up, grabbing something from the top, and never when they're turning. So I do the deep head hang in those rare occasions, but yeah.
Yeah. So Lillian, quick question for you guys and Gift. When you're in the vestibular clinic, you guys have a pretty common battery of bedside vestibular tests that you're doing, kind of like what Batul just went through. You do head shake, do you do head thrust, check for Dix-Hallpike maneuvers, do you do central like cerebellar testing? And can you kind of maybe give us a quick brief, like what do you guys test? And do you have Frenzel glasses, or do you ever use those? Do you ever use Frenzels?
Yeah. So in the clinic, we do have a test battery that we do. So once we finish to the history of the patient, we perform on all patients. We actually do an ear exam, and then we do a cranial nerve tests exam. Then we look at we do a VOR. So we do the gaze. Then we do smoke pursuit. We do all the oculomotor tests. Then we do sometimes we do gait. And if we do gait, then we combine gait with Rombergs. Not very common for us to do Fukuda, but it's not commonly done. What we commonly do is a hyperventilation test. And we do a test of skew. On almost all the patient, hyperventilation test of Q. And then when we're doing the Rombergs, we do the sharpened Rombergs in some of the patients. So those are the common tests that we do. And we finish with blood pressure, supine and seated. And then we do Dix-Hallpike tests.
So you do orthostatic blood pressures on everyone?
Most of the patients, yes, especially
Or the
those
ones
who
that just come?
have, it's based on the history.
Mhm.
So some patients, not all, but for all patients, we do a head shake, head thrusts, a hyperventilation tests, cranial nerve exam, and and the oculomotor test. That is a standard for almost all patients.
Hmm. Nice.
Lillian, did you say you do a skew test?
Yes, we do a test of skew.
How do you do that? I'm not familiar with that term.
We use a piece of paper. We do the cover and cover tests.
Mhm.
So we use a piece of paper and then we ask the patient to fix on one point. We cover one eye and then we just suddenly cover and change the sides and check for any deviation in the eye movements after some time.
Mhm.
Yeah, yes. And we do have Frenzel glasses, but at the same time, we also have we have modifications. So sometimes we use a blank piece of paper, and we ask the patient to fix on a target that is far off beyond the paper if we want to like suppress their fixation, their view. We also have there's some new glasses that are available online. They're quite cheap and affordable at Take a Lot. They're like they're video game glasses. They are 3D video game glasses, but they can act as VOR glasses. They're made of cardboard and they're very efficient because they're sort of like covered on all sides. So they're very good for helping the patient to fix it. And because they are 3D glasses, they kind of act like Frenzels. So I'm gonna be taking home a pair of the cardboard glasses because in my facility we don't have Frenzel glasses, but with time hopefully we'll get them.
Nice. I think one thing it's really important to ask before I start, I always check for history of cervical spine issues, like fragile, like older spines, spine surgery, before I start doing a lot of head thrusting and manipulation. You don't want to do that. I think a big thing is one of the biggest limitations of the bedside vestibular test is that, right? So you always want to ask and make sure you're not potentially harming someone's, 90-year-old spine or somebody who's had, relatively recent neck surgery or spine surgery. I think it's really something to think about too. That's always and that can be rate limiting. So I just say, well, you may not get that data. You might have to just turn to formal testing, where you're not going to be putting them in harm's way.
Yeah.
Yeah.
I think part of what we are taught in the clinic here is as we do the cranial nerve exams, as we are doing the 12th cranial nerve, we check the range of movement, the cervical range of movement. So we ask the patient to tilt forward as much as they can, backwards, pretend they're holding the phone, and then on each of the side. And that gives us a rough idea of how ready they are for some of those movements. And then we also ask the patient.
Yeah. Yeah, and I think educating patients is really important because I think some people have the impression that all dizziness is ear. It's the ear all the
And in my
time.
third slide.
And they don't appreciate its vision, its orthopedics, its proprioception, it's brain, it's multifactorial. So I think it's an opportunity. And then I think, kind of what Batul said at the very beginning, the other big thing I think is that patients, they say they're dizzy. They say they're dizzy and nobody really ever asks them, what does that really mean? So I kind of stop them early. I say, okay, I want you to tell me about your symptoms, but you can't use the word dizzy in the description at all. Because I think what some patients might describe what they think is vertigo, when you drill down on that and ask them to be very specific, many times it's not. And they're dealing with, arrhythmia or orthostatic hypotension or something else. So I think the clarity of communication is really critical. You can uncover a lot within the first 2 minutes of talking to folks. And they've been carrying this dizziness descriptive for like provider to provider to provider. And then they're like, oh, go see the ENT doc. See the ENT doc. It's got to be the ear. It's got to be the ear. It turns out they've got AFib or something like that, or first degree heart block or something like this, right? And you're like, wait a second. Did anybody ever ask these people what's really going on? So it's really interesting. These conversations, there's a lot to these conversations. So yeah.
We're doing like it's more of a qualitative study because I was on that note where like it's always different. Like, what does dizzy mean? So we interviewed 10 patients that have inner ear pathology diagnosed by like ENT and vestibular testing, 10 that are more neurological who are seeing neuro for it looked central but had other stuff, even like vestibular migraine fell in the neurological category. And then another 10 where they had other, where it's cardiovascular. And then all the way they described it, it like merged into one. Right now it's getting coded, and there are certain word triggers that aren't commonly used that they randomly throw into their case history that are truly indicating where they should go. We think. We'll see.
Yeah. Yeah.
But it's
Well, there's a
interesting.
code that's called dizziness and giddiness, which I've always like, wow, what that's actually a diagnosis code.
We've had a few
Giddiness.
people be upset by that diagnosis.
I don't even know what giddiness is. And you guys might have to describe, you guys might have to tell me what giddiness. I always thought giddy means you're like, oh, you're being kind of
Happy.
silly or funny.
Yeah.
Yeah. Yeah. That's not a bad thing, right?
I wouldn't call the patients we see giddy. No.
Right.
would
That's a word I can honestly say I've never placed in one of my clinical record or my clinical notes. Giddy. Unless the patient would have said that, but I don't think anybody's ever actually said that to me.
Not yet. Careful what you wish for.
The day's not
First
over.
back into clinic.
Let me see, 3 giddy patients first week. All right. Well, that was great. Any other comments?
Okay.
No,
Great talk.
Thank
Thank you.
Well, thanks for
much.
listening to me
Excellent.
for an hour.
Oh,
Yeah.
no, that's great. Batul, thanks for being up so early, and thanks for that. It was really great. Brad, I'm sorry, Brad, you can come on. Brad Welling, this is Batul, Brad's at
Hi.
Harvard. Batul is one of our audiologists. A chance to introduce you guys.
Yeah, great talk.
Beautiful
Thank you
sunny
very
day there in
much.
Boston.
Well,
Looks like it's always sunny in Boston every time we see you. That's beautiful.
Yeah, it
Mhm.
is. Looking over the Charles this morning, it's lovely.
Nice. You better get on the boat. You better get on the boat. So, all right, guys.
All right.
okay,
Thank you.
thank you very much.
You guys.
Well, happy New Year to everybody. We'll see you guys next week.
Yeah.
Next week. Sure.
Yes. Over
Go
there.
Bucks.
All right.
Yeah.
Hey, Batul, can you stay on for just a second? I was gonna talk. We can
Yeah.
chat about that. Yeah.
Yeah.
All right. We'll see you later, guys. Take care.
Bye.
Have a nice
Bye.
weekend.
What do we do for next week?
What's that?
What do we prepare for next week? Do we prepare a case,
Uh,
or are you going?
That's right. Do you guys have a case?
Well,
Maybe.
not really, but
Maybe.
we did a subtotal petrosectomy on a patient, a trauma patient. It was the patient had an
okay.
aortic capsule violating fracture.
Oh, okay. Okay.
I don't know.
Yeah.
I don't know. Should we
Okay.
talk about trauma?
Well, we could do trauma. Yeah, that would be great. We haven't done trauma in a little while. If you'd like to talk about that, that'd be great.
Mhm.
Do you guys want to present from your end?
Yeah, sure. We can prepare.
Okay. Yeah,
Yeah.
maybe talk about that, and then you can talk about that case too. That'd be good.
We'll prepare, and then we can present this patient's scans.
Oh, that's perfect. That sounds
Yeah.
great.
Okay.
Excellent. Nice to see you
fine.
guys.
Thank you. Nice
Bye-bye.
to see you.
Have a
too.
good
Bye.
weekend.
Bye.
Bye.
Thank you so much.
Bye.
Thank you,
You're
Gary.
welcome.